All right, thank you. You got my 10 minutes on there.
Sharp.
Sharp, yeah, absolutely. So I'm going to shake things up here and talk about vasomotor diseases or lower extremity vasoacrosyndromes. You think about it, it's kind of hard to come up with a conflict of interest for vasomotor diseases. So hopefully, I'm going to use a pictorial-assisted talk today, and hopefully by the end of my presentation, you'll be able to correctly identify what's causing these toes that look like this, feet that look like this, skin that looks like this. So here's our first vasomotor acrosyndrome. What is going on here? Gosh, what could this be? Could this be Raynaud phenomenon? Well, how do you make the diagnosis of Raynaud phenomenon? Well, there are two integral components to diagnosing Raynaud phenomenon. Number one, a history of digital cold sensitivity, and number two, episodic, well-demarcated pallor or a blue-purple discoloration, or both, of the digits upon cold exposure. You often have attendant numbness and tingling, and these vasospastic episodes usually last between 15 to 20 minutes, and you may or may not have a concurrent pink or red hyperemic phase with warming. So a lot of clinicians are incorrectly taught that in order to make a definitive diagnosis of Raynaud phenomenon, you have to have this triphasic transition from a white attack to a blue attack to rubor upon a warming. That's clearly not true. In fact, only a minority of patients actually display this classic triphasic color change. In some studies, it's as low as 1 in 5 patients actually have this classic triphasic color change. So what about cold immersion testing to make the diagnosis of Raynaud phenomenon? Do you need to immerse their feet or toes in ice water or snow? Well, that's a big thumbs down. And this is a comment from Fred Wigley in Up to Date, this 2023 reference. Fred Wigley is the guru of Raynaud phenomenon. And he says the following: attempts to induce an attack, such as with cold water challenge, are not recommended since the responses are inconsistent, even in those with definitive or definite Raynaud phenomenon. And in fact, if you have a patient as a secondary cause for their Raynaud phenomenon, like scleroderma, you can actually precipitate an acute ischemic crisis, and that patient ends up in the hospital with 2 to 3 days of refractory digital vasospasm. Raynaud phenomenon is a clinical diagnosis: well-demarcated digital pallor, cyanosis, or both. That's it. And so to make this diagnosis, you have to witness either the white attack or the blue attack or both. And this can be done in two ways. It can be either done in your office, in the clinician's office, and that's very unlikely. Every once in a while I'll see it, but more often than not, it's going to be via photographs or video. So the patients bring in their cell phones, and inevitably they're scrolling through hundreds of selfies and pet photos, and finally they'll find a photograph. There may or may not be consistent Raynaud phenomenon. If you saw that, you'd say, yeah, that's obvious Raynaud phenomenon. Now, often I have a lot of patients that come in and tell me, I'm here to see you for Raynaud phenomenon, but really they just have cold intolerance. And it goes back to, can you show me a photograph of toes that look like this? And sometimes the patients are elderly, they don't have a cell phone, they don't have photographs, and so I'll pull up Google Images and I'll show them representative photos, and more often than not, they don't have true Raynaud's, whether it's cold intolerance with some vasospasm. So often confused with Raynaud phenomenon is the vasomotor disorder acrocyanosis. And this is palpably cool discoloration of different shades of red-blue in the distal parts of the body, hence the term acro. Now, this discoloration may extend to or even above the wrist as well as the ankles. You can see here, there's discoloration going all the way up above the ankles. In the other case, it's only to the midfoot. This discoloration, like Raynaud phenomenon, is exacerbated by cold. It's improved with warmth, yet unlike Raynaud phenomenon, this discoloration persists. The discoloration is increased with limb dependency, and it's improved with limb elevation. And again, just want to emphasize the skin is palpably cold in these patients. And I think a lot of these patients actually come in with so-called cold intolerance. They probably do have mild acrocyanosis. It's just undiagnosed. Acrocyanosis, it's important you realize it's associated with different shades of discoloration. A lot of times people are so dogmatic and think that the feet have to look like the example there on the left-hand side of your screen, these deeply cyanotic feet and toes. I'd say more often than not, I see what you see in the middle part of the screen. It's more of a red-purple discoloration or erythrocyanosis. And then rarely you see these variants where there's just sort of a pink red discoloration in the case on the right-hand side of the screen. And you can see there's where the discoloration extends about up to the right midfoot. Now, a unique physical finding in acrocyanosis is the Crookes sign, also known as the iris sign. And the iris sign is when you blanch the skin, you see the return of blood flow from the periphery to the center, as opposed to just filling from below in somebody that doesn't have acrocyanosis. And I'll show you an example of the great example of the iris sign. That's a great iris sign. Can we reverse that and just show it one more time? It's fun to watch this. I mean, it really is. One more time. Okay, here we go. There's our Crookes sign. Crookes was actually a colleague of Raynaud. He was a French physician, by the way. Now, it's imperative that you distinguish between the well-demarcated digital discoloration of Raynaud phenomenon and the fixed discoloration of acrocyanosis, which, by the way, like you see in the right-hand side of the screen, is not well demarcated. Just the margins are kind of blurry, as you see here in that right foot. And of importance, acrocyanosis itself is not associated with pallor. Only Raynaud phenomenon is associated with pallor. So here's another acrosyndrome. You have a 34-year-old female, I'm sure Peter's seen many of these, 31-year-old female with recurrent digital ulcerations every winter, have attendant burning, itching with swollen cold toes, and the distal pulses are easily palpable. What are we dealing with here? Now, Peter, do you see this in Arizona? Because I know you probably saw so many cases in Minnesota, but you probably don't see it in Scottsdale, Arizona. Yeah. Well, this is Pernio or Chilblain's disease. And Pernio or Chilblain's disease is a superficial, localized, cold-associated, lymphocytic-mediated inflammatory skin disorder that looks like this. And as opposed to frostbite, this occurs upon exposure to humid, non-freezing temperatures. And when you look at data from Peter's institution, Mayo Clinic, 80% of these patients were female with a mean age of 38. And note that substrate there is very similar to what you see with the typical case of Raynaud phenomenon. So here are 4 highly illustrative examples of patients of mine with Pernio or Chilblain's disease. And in addition to seeing the discolored purplish red toes, you also will see macules, you'll see blisters, you'll see ulcerations, and then very importantly, because this is a lymphocytic mediated inflammatory disorder, note the bulbous appearance of the toes. They're very, very swollen because of the associated inflammation. And this is best visualized from a plantar aspect of trying to, as opposed to looking at them from a anterior approach, so to speak. Now, as opposed to the acrosyndromes I just showed you that are all associated with classic polar, this disorder is associated with burning, red, hot, painful feet. Has anybody seen this before? These are paroxysms of just burning. What? Erythromelalgia, outstanding. This is erythromelalgia. Also called the man on fire disease. I think actually a better description would be woman on fire disease because this is twice as likely to affect a woman than it is a male. But this is the vasomotor disorder erythromelalgia. This has been referred to as the antithesis of Raynaud phenomenon. And it's associated with the clinical triad of erythema, increased warmth, and painful burning. And in contradistinction to Raynaud phenomenon and acrocyanosis, it's actually aggravated by warmth and it's relieved with cold. 2 good examples. Now, this is not necessarily an acrosyndrome, but it often coexists with the acrosyndromes. What are we looking at here? The reticular net-like discoloration of the ischemic dermopathy, livido-reticularis. So look for this in the background of your acrocyanosis. And this is a nice segue into the last slide on acrosyndromes. These are often vasomotor hybrids. That is, Raynaud's attacks can be superimposed on acrocyanosis. That's not uncommon. Now, like I said, acrocyanosis itself does not cause pallor, but it can be associated with superimposed Raynaud phenomenon. Acrocyanosis and Raynaud phenomenon may coexist with Pernio or Chilblain's disease. And in fact, I would submit to you the majority of these patients you see with Pernio, they probably do have acrocyanosis and often Raynaud phenomenon. Erythromelalgia can coexist with acrocyanosis and Raynaud phenomenon. And this often confuses the untrained clinician because these erythromelalgic flares are paroxysmal. And when they're not flaring, they actually have acrocyanosis. So the majority of the time, they're spending their state in with purplish cold feet. But when they flare, then they become red and hot. And that can confuse a lot of untrained clinicians. And then finally, livedo-reticularis often coexists with all of these acrosyndromes. And there's a great example right there. Note the feet are just a little bit violaceous. That's acrocyanosis. And then you see the associated livedo-reticularis. Same thing, livedo-reticularis, but you see the burning hot red feet of erythromelalgia.
Yeah, let's
Thanks for your attention.
yes, yes. Yeah.